This is Rory Spiegel and Ryan Radecki, and this is the Annals of Emergency Medicine podcast. It's May 2025. Ryan, how you doing?
Still May 2025. Doing great.
Yeah. All right. Should we hop right in? I think we got a full docket today.
Yep. Tons of articles to talk about.
All right. Well, I think I have the first one. And it's changes in behavioral health visits, operations, and boarding in a pediatric emergency department. And the lead author is Joel Hudgens. I think for anyone who actually works in an emergency department is fairly aware that behavioral health visits and boarding is becoming a big problem. The more we have, the more it affects ED efficiency and care for all our patients. But we don't really know is the same effects that we're seeing in adults, are we seeing the same thing in pediatrics? And so what these authors did, they conducted a retrospective cross-sectional study at one large pediatric emergency department over a 12-year period from 2010 to 2022, involving over 700,000 visits. And they looked at the amount of patients per year that presented with behavioral health complaints. And they classified this as any patient that required the presence of a security sitter, which was part of their standard care at their institution. They classified the behavioral health hours basically defined by the length of stay of those patients, and boarding was defined as the length of stay of 12 hours or more. Then they looked at these behavioral health patients, the amount of time we were there, how much boarding, and they compared it to 7 operational metrics across the ED, basically to kind of get an assessment of how care was being delivered throughout the emergency department, not just with the behavioral health patients. And these metrics were divided into 2 categories: throughput metrics, so vital signs within 30 minutes, use of hallway beds, patient leaving without being seen, waiting times, and then care metrics, time to medication administration and time to disposition. And they basically compared the increase in behavioral health care and hours to the effects on these metrics. And so over this 12-year period, behavioral health visit rose from a little over 1,100 patients in 2010 to over 2,500 patients in 2021. Hours of care increased as well, and then boarding dramatically increased by 61%. So what they found was basically for every 5% increase in behavioral health care hours, you saw worsening of basically all their metrics: a delay to vital signs, increase in hallway beds, longer wait times for patients, more patients leaving without being seen, more patients waiting longer for antibiotic administration, more patients waiting longer for dexamethasone administration, and then longer times for disposition. So, I mean, I think this is something that we all could have guessed. I don't think this is isolated to pediatric patients. We exist in a zero-sum game. You know, we focus more on one thing, we take resources away from something else, and overall performance everywhere else goes down. It's not surprising that if we're seeing these problems with adults, we're also seeing these problems with pediatric patients. Again, this is, like we've talked about so much, this is not an emergency department problem, but a societal problem. The emergency department is the symptom and bearing the brunt of it.
Yeah, I mean, this is insane. I mean, you could just look at like figure 1, graph A, and you can look back at 2010 where it's like, oh, there are a few children in the emergency department with behavioral issues and we had to take care of them. And it's like, oh, wow, man, it like doubled by 2014. And then it's like, oh, wow, 2019, oh, it's doubled again. And then it's like, oh, January 2021, oh, it's doubled again. And it's just an insane burden on this emergency department. And that's probably fairly generalizable to tertiary centers like this around the country. And then, yes, obviously, once you are devoting all these care and resources to, these are can be pretty high intensity, high maintenance patients. Obviously, you don't have the nursing resources to do the things you need for the patients who are sick with medical issues. Not to say that these mental health patients aren't sick as well, but geez, it's stark.
Yeah. And, it speaks to the same problem we come up with always, that when we focus our care on one type of patient, care for the rest of our patients suffer, whether it's trauma codes, stroke codes, heart MI codes, so on and so forth. We might be able to improve metrics in that one area, but everything else suffers because of it.
And then naturally it circles back to like the core tenet of emergency medicine. It's like front door problems are fixed by fixing the back door problems. And this is getting these children the appropriate care they need in a timely fashion and dispositioned where they need to go to be safe is a backdoor problem. And if you fix that problem, you can fix a lot of other issues that are going on in these emergency departments.
Yeah, I mean, not to mention fixing the social economic problems that led us here in the first place.
Well, once we fix it's all about chronic disease and our diets and raw milk.
Seed oils, got to fix the seed oil.
Yellow number 5. All right. Moving on to the next little article we'll talk about in this issue. It's called Skin Glue to Reduce Intravenous Catheter Failure in Children. Our lead author is Owen Chawan, and they're at Dalhousie University in Halifax, Nova Scotia. And no one wants to unintentionally lose intravenous access, and particularly no one wants to lose intravenous access in children, where access may be more traumatizing and difficult, generally speaking. Hence, the various mittens and boards and all those other things in common used to prevent dislodgement. A couple years ago, a group out of Australia published a randomized trial in which they demonstrated a specialized dressing, usually used for central lines, in conjunction with skin glue, was superior than usual care alone. These authors have asked the question, is it the special dressing, or can we get improvements in rates of dislodgement using our conventional skin dressings plus the skin glue? Well, randomizing about 250 kids into two arms, one of which received a drop of skin glue at the catheter entry point into the skin, the rate of inadvertent discontinuation was identical between arms. Haha, no pun intended. So in any event, no. This method of preventing catheter dislodgement in pediatrics does not offer any advantage. The small added advantage of skin glue seen in the cited trial, if true, probably it cannot be generalized from that specific dressing used in conjunction with it.
Also, they basically splinted and mummified these arms so nothing could get out of them. And if the kid is going to be able to somehow get that IV out of, a splinted arm that's been taped completely up, I don't think a drop of skin glue is going to be the thing that stops it.
But it's super glue. So yeah, it's just not this one drop is not the magic difference. That's basically what this story shows. There's more to it. Find a complex method of other dressings. I mean, the bulky dressings that you use for central lines, must be better in some fashion if it's generalizable, or their technique was generalizable, or their usual care was terrible. It's hard to say exactly what's going on here, but you don't have to put a drop of skin glue on there.
Yeah, or everything else you've done to bind this thing into place is either going to hold it in or not. And the tiny bit of skin glue isn't going to make the difference. So moving on, staying in the pediatric realm, our next article is incidental findings on computed tomography in children with blunt abdominal trauma. We all like incidental findings. We have to document on it. We have to make sure the patient has follow-up on it. And with our increasing use of the CT scanner, we're obviously finding more and more incidental findings. Now, one would think with kids, you find far less incidental findings than you see in the adult population, but it's never really been quantified in a study. And so what these authors did essentially was a secondary analysis of a large multi-center prospective cohort study where they looked at children 18 years or under who presented with blunt abdominal trauma. And they looked at the subset of patients who were getting a CT scan of the abdomen and pelvis. Now, these CTs were originally performed for traumatic injury, and radiology reports were reviewed for non-traumatic incidental finding by trained abstractors. So this is an important note. They weren't looking at the CT images themselves. They were just reviewing the radiology reports to see what they could find any non-traumatic incidental findings. They then assessed these findings to the urgency of follow-up needed. And they basically created a 5-tier system, 1 being immediate evaluation, 2 being urgent follow-up within 4 weeks, and then 3, 4, and 5 less urgent follow-up, 5 being no follow-up required at all. You had 2 pediatric emergency physicians and 1 general emergency physician read these reports and categorize the findings, and then a pediatric surgeon adjudicating disagreements. The primary outcome was the prevalence of incidental findings on CT and their clinical urgency. So in this study, there was over 7,500 patients enrolled. About 30% or 2,500 patients underwent CT imaging. The mean age was 10, 58% of them were male. 988 children, or 40%, had an incidental finding found on their scan, which in my mind seems pretty high. 40% of the kids you're scanning, you're going to find something that you don't expect that has nothing to do with the trauma. But let's kind of break that down a little bit. They actually found a total of 1,552 incidental findings. So the mean was 1.6 findings per child. The most common were in the GI tract, bone, and then kidney. Now, in terms of follow-up urgency, 3.5% required immediate evaluation. And these were masses that were suspicious for cancer. 1 patient had appendicitis, and 1 patient had drug packets ingested. Rather important findings that we might not have found if not for the CT scan. Now, 5.4% required urgent follow-up, which was in the next 4 weeks. And the majority of the patients, 70%, had routine or no follow-up needed. Interestingly, there was a wide wide variability across sites upon incidental findings, ranging from 26% to 53%, suggesting that the radiology practice may influence reporting. So, I mean, I think this is an interesting study. I think it goes a long way to showing that the same problems we're finding with incidental findings in adult, we're finding in children. I think it's fairly interesting that it's highly dependent on radiology readings, where the incidental findings could be down to a quarter to up to a half. And again, it really speaks to that idea of how much do we have to do with these incidental findings, and one could suggest overdiagnosis in a lot of the cases. Now, there's a couple limitations with this paper. This is a post hoc review. They didn't actually follow up on these patients. They didn't see what was done with these patients. So it's a little unclear how many of these findings went on to be true pathology that needed to be intervened on, and they didn't really see if their follow-up was actually validated, meaning if the patient could actually wait 4 weeks for follow-up, so on and so forth.
Yeah, I mean, this is basically just, if you've ever read a radiology report, they just go through by every single structure and make some comment on it. And they have a list of all of their incidental findings in an appendix. And even the ones they say that require follow-up are like appendicolith, dilated hepatic ducts, horseshoe kidney. I mean, some of these there's not really any follow-up. They're definitely incidental findings. They really don't do a good job of dividing this up into clinically important necessarily versus not clinically important. Joint disease, Schmorl nodes, anterior listhesis, retrolisthesis, these are all on their routine follow-up section. And these are the kinds of things that there's not really anything to do for in follow-up. And then there's a whole list of even potential need for follow-up, and there's a whole list of benign things. So yeah, I think the part where it's like a very tiny fraction of these are actually important incidental findings, and the vast majority are just like, oh, look at that. A Phrygian cap on the gallbladder. Wow. It's really just, did they get a radiologist to read the study? It's not so much like, is there an incidental finding? Just that these are all essentially normal variants or variations on normal to some extent.
This is a problem of modern medicine, essentially.
Yes. And now now they have a pre-existing condition and they won't be able to be insured. Oh, it said when you were 5, you had a Phrygian cap. Definitely overstates the relative importance of these incidental findings, but I do like that they found some drug packets in some of these people. It's like, what? But I guess it depends on the age of the child and the clinical setting in which that trauma CT was performed. Grim. Well, moving on and getting out of the pediatric realm, I hope. This next article we'll talk about is called "A Comparison of Ketamine to Midazolam for the Management of Acute Behavioral Disturbance in the Out-of-Hospital Setting." Our lead author here is Maeve Muldowney, and they're at the University of Washington. So, of course, management of acute behavioral disturbance is an unfortunate reality of pre-hospital care. There are, luckily, several different options, each with their own specific pharmacology and adverse effect profile. The classic sedative classes are benzodiazepines, but it wouldn't be emergency medicine if we didn't readily volunteer ketamine as an alternative. So this is just a retrospective look back at a single emergency medical services experience after adding ketamine to their pre-hospital behavioral disturbance protocol. In the midazolam corner, pre-hospital protocol allowed for 1 to 5 milligrams of intramuscular or intravenous administration, repeated as needed every 2 to 5 minutes. In the ketamine corner, the option was a 5 milligrams per kilogram intramuscular dose up to 500 milligrams. Then the authors reviewed 2,898 EMS records where the search terms midazolam or ketamine were included, resulting in 376 records in which the study authors judged the purpose of midazolam or ketamine administration to be to facilitate the safe transport of a patient with acute behavioral disturbance. This cohort was split into 162 patients who received midazolam as an initial management strategy and 214 who received ketamine first. Midazolam-treated patients typically received 5 milligrams as their initial dose, while effectively all ketamine first patients received 500 milligrams. A handful of patients in each cohort crossed over to receive the alternative sedative in the pre-hospital setting. Outcomes, generally speaking, are not reliably distinguishable. A little over 10% in each cohort required pre-hospital airway intervention, mostly endotracheal intubation. Another 10 odd percent received advanced airway management in the emergency department. Downstream sedative use in the emergency department was generally similar, and about half of each cohort was ultimately admitted to the hospital. Grossly speaking, there was not a profound difference between outcomes in this retrospective evaluation, and that's the key: retrospective evaluation. We don't know if there are patient-specific factors determining which sedation strategy it was chosen pre-hospital, so we can't rely upon this report to say ketamine or midazolam would be universally appropriate. Then the search strategy is a further limitation, as the authors performing review of charts were unblinded to the hypothesis regarding the appropriateness of ketamine. 1,300, or half of patients, were excluded at the first step because those patients immediately underwent endotracheal intubation, and it wouldn't have taken but a few of those to have cascaded into the study cohort to dramatically alter study conclusions. Finally, it should be noted that these are not the only options. Haloperidol, droperidol, and a variety of antipsychotic agents can be considered for acute behavioral disturbance as well. So yes, ketamine grossly has face validity regarding its effectiveness as a relatively safe agent for treatment of acute behavioral disturbance, but further prospective data would be desirable.
I think the biggest thing that this paper serves is to combat that paper out of Hennepin about 5 or 6 years ago, where they did a very similar methodology and showed that there was like a 33% rate of intubation in the ketamine group. And when you dive into the paper, you turn out it was all done by one guy who was receiving the ketamine patients in the hospital, and obviously didn't feel too comfortable at them being dropped into the K-hole and just intubated. And so this is nice to see that, yes, that was probably just practice variation, which really biased that study, and the likelihood is that probably the results relate closer to this. One of the things you would have liked to see here is the big problem with ketamine is not the safety of intubation. It's not the speed at which you put people down. It's that they wake up 15 minutes later and still acting a little bit crazy. And so usually you need something on the back end to keep them sedate. And so it would have been nice to see how often it needed a rescue medication compared to the midazolam group. Otherwise, yeah, I think obviously, this study is limited by the methodology that it's done with, but more data would be nice.
Yeah, I mean, and again, there's other options as well. So, I mean, whether you're, like you say, the longer acting antipsychotics potentially are going to give you some better benefit on the back end if you get them on board early. I mean, it's midazolam, but it's not midazolam plus, droperidol or plus haloperidol. 500 milligrams of ketamine will work on a lot of things, to put it mildly. But in theory, is this the best option? No, but it's definitely an option for the appropriately selected patients.
The way I look at it is, you've got your fast acting agents like your benzos and ketamine, which are meant or intended to put the patient down immediately. And then you have your antipsychotics that are meant to give you kind of that long acting effect when those initial agents wear off, much like in a seizure patient. You have your benzos up front, then you have your anti-epileptic on the back end to kind of prevent the seizures over time. Usually with all these fast-acting benzodiazepines or ketamine, you're going to need some kind of antipsychotic afterwards to maintain the effect.
Although ketamine has a special property of kind of resetting people. So, but anyways, yes. So limited slice of data here, obviously, but it's another piece in showing this general safety and availability of ketamine.
Yeah, and I think as a specialty, we've become more and more comfortable with the use of ketamine. So it's not surprising these results differ than the other study. All right, our next article, virtual observation units and physician well-being. And the lead author is Olivia Young. So telemedicine is becoming more and more popular. And with the growth of telemedicine into the emergency medicine field, one of the areas that is being worked on are virtual observation units, which is essentially observing a patient from their home. That allows patients to be discharged from the emergency department and have ongoing follow-up through telemedicine, being seen by both nurses and physicians. In certain cases like this, an EMT will visit the patient to get hands-on exposure to the patient over the follow-up period. And what this study basically looked at was a qualitative study involving 10 emergency physicians who had worked in this newly launched virtual observation unit in a single hospital in Boston, got their thoughts on the unit and basically what they thought of the unit themselves, what they thought about it as far as work-life balance and well-being and so forth. The physicians had to volunteer for shifts to manage patients in this unit. authors conducted semi-structured interviews with thematic saturation, with the primary outcome was to understand physician experiences, positive, negative, and unexpected. Basically, three themes kind of emerged through the use of these semi-structured interviews. The first one was deeper connection with patients, which initially I thought was kind of funny that you needed a telemedicine shift where you don't actually get to see or touch the patient and you're just looking them over a screen and you develop a deeper connection. But the physicians basically felt they had the time to spend more meaningful time and interactions with their patients because their visits were essentially scheduled for a 45-minute block, and they weren't in that period intended to see other patients. They weren't, task interrupted like we are so many times. And they could actually spend 45 minutes with the patients, seeing them interact at home, their families, so on and so forth. And it gave them more a sense or a deeper connection with their patients. The second theme was enhanced interprofessional teamwork. The doctors worked closely with the nurses and the paramedics through this virtual telemedicine rooms and basically co-manage the patients. And again, I think it basically was the fact that you're intimately working with one nurse, you're working with a paramedic who are basically your eyes, your ears, and your hands on site with the patient. And it just creates a smaller cohesive team that you need to work with. And then the last one was like the problematic challenges that came up that basically obstructive care. And a lot of this was just like the logistics of the telemedicine system and didn't exactly connect with their EHR. And then to actually, if they wanted to contact the patient's primary doctor, they then had to call on a telephone. And it wasn't a cohesive system that kind of was built together. And they often felt like they kind of had to string things together with duct tape, which is one of the most important emergent medicine skills, right? Is just to make things work. All in all, I think it was interesting. I think they found things that I would have not predicted. I would have thought, you would have felt farther from your patients, less like you were doing medicine, kind of detached, but it seemed to be the opposite. And so maybe this does potentially some physicians kind of add to their work-life balance, improve well-being, so on and so forth.
Yeah, I mean, I think the key is that they selected physicians who volunteered for this. And it's not really surprising that they were satisfied with the experience of giving the care that they volunteered to give because they volunteered to do this thing they wanted to do because they thought they would like it. So it's like a self-fulfilling prophecy to some extent. This whole telemedicine thing and this virtual emergency department thing and the virtual observation, it's all going to increase, whether it's, it doesn't have to be done by emergency medicine. It can be done by lots of different specialties, but it is obviously a different type of work than you get in the emergency department. And for some people that checks a box, which is great. Indeed. Staying on the telemedicine sort of topic, the next article we'll chat about is called Estimating the Proportion of Telehealthable U.S. Emergency Department Visits. And our lead author here is K. Noel Toon, and they are at Massachusetts General Hospital, just kind of like where that last study was performed. There's no question that a portion of visits to the emergency department could be evaluated in another setting or by using a different set of resources. Indeed, many departments operate a fast track where patients with minor complaints are seen by sometimes even non-physician providers. This is a little different, step beyond fast track, but to telehealth, where further limitations in examination, testing, and fidelity are present. I'm a bit hesitant, though, to get into any detail regarding their results, however, because of their methods. These authors basically reviewed a representative sample of the 2019 National Hospital Ambulatory Medical Care Survey, looking at these 19,000 ED visits for two data points in order to classify them as potentially eligible for telehealth: the 825 different reasons for visit and patient age. That's it. And then they used a threshold of at least 80% chance a specific reason for visit seemed appropriate for telehealth as their breakpoint for very likely, but then allowed for possible, and then actually used two different types of telehealth: regular old face-on-a-screen telehealth and telehealth plus, where a local facility could be used to obtain basic blood work and radiography. Also further stratified their telehealthable classifications by age, using pediatric cohorts, young adult cohorts, middle-aged cohorts, and older adults starting at age 65. So these data can only be seen through that imperfect, low-information lens. And, well, the answer is basically a small portion, where a small portion can likely be evaluated by video only in the nebulous area around or below 5%. Adding blood work and additional testing increased the proportion eligible for telehealth by somewhere around double in their subjective evaluation. and it was more acceptable to refer young people to telehealth than the older folks. So obviously, since this is an AMCUS and the authors go and multiply this out by the millions of emergency department visits every year, and yes, it's true, even a small fraction of hundreds of millions gives the potential for millions of ED visits safely diverted to telehealth. So certainly, I agree telehealth resources could be used to augment limited physical ones. While the accuracy of these data not ought to be relied upon due to their methods, it is probably reasonable for policymakers to consider, as part of health system design, to resource telehealth to take the strain off of burdened physical departments.
Yeah, I mean, I think this is a good idea. I think, again, like with this data, you have no idea really what the numbers are. And it could vary widely from what they're stating here. And until you start doing it and implementing, it's hard to know. It's also hard to know if this is the best use of telehealth resources versus like the back door, right? Getting people out of the emergency department who are seen to a safe follow-up, like a telehealth observation unit or team. I think in the end, we just need more data on both these areas before we can kind of make definitive decisions.
Yeah, I mean, I wouldn't say that this is 5% or 10% telehealthable. A small percent. We know there's a small percent just by going to the emergency department and working there every day. A small percent could be seen by somebody telehealth screen and then maybe even telehealth plus. Great. They just need to use more granular data to actually make that determination. Use a richer data set, not just age and chief complaint. I know maybe that's sort of like they're trying to simulate with this patient, like what you might have over like a triage nurse hotline or something like that. But you can probably gather a little bit more information on a triage nurse hotline to get the critical information to know whether the patient could be seen by telehealth or not. There's time to get more than just a chief complaint and an age. So maybe use Epic Cosmos or some other, some other massive data set collected by, I don't know, health insurance companies or so on and so forth. But NAMCAS just doesn't have the appropriate data for this analysis like this.
Yeah, agreed. All right, moving on. Our next article, extracorporeal pulmonary resuscitation outcomes improve with center experience. Not a shocking conclusion. And the lead author is Michael Pope. The debate on whether eCPR is beneficial from a societal perspective, I think, is still undergoing. The debate whether you can save someone's life with eCPR, I think, is fairly conclusive that from time to time you can, but it requires a well-structured, well-oiled, efficient team to do so. Essentially, you have to quickly and effectively cannulate someone and put them on bypass while they're in arrest. And you have less than an hour to do so. And what these authors did was essentially a retrospective cohort study looking at 192 patients that they put on eCPR over a 3-year period. And they essentially looked at the outcomes over that time. And during this time, there was a lot of quality improvement processes that were going on with their eCPR program. They were developing pre-hospital selection criteria and pre-alerts, implementing in-hospital ECMO protocols, regular interprofessional training, and then real-time feedback and quality assurances were ongoing over that period. The primary outcome was looking at the 6-month survival with favorable neurological outcome score, which they defined as a CPC score of 1 or 2. And then they also looked at other qualitative metrics, low flow time, bystander CPR rates, shockable rhythm, and case selection accuracy. So over the period, they showed that they had an improve in neurological outcomes with neurological survival improving from 15% to 37%. Among out-of-hospital arrests, they saw an improvement from 7% to 32%. Now, that seems good, and it might simply be due to their improvement in team function, cannulation time, so on and so forth. But it looked like they were also improving patient selection. Bystander CPR increased from 77% of the patients to 95%. Shockable rhythm rose from 65% to 76%, and low flow duration dropped from 78 minutes to 68 minutes. So simply by selecting patients that are more likely to have a favorable neurological outcome, you're going to come up with patients that have a more favorable neurological outcome. I think this is a nice study. I think it does show that as you improve your team and you improve your services, you work on quality improvement, you're bound to get better results, whether that is just selecting better patients or getting better at the actual process of putting someone on pump in a quick and efficient manner. I think is still unclear.
Yeah, I think the key is that patient selection bit. And the other thing I think about is like when I see their little survival graph and it starts in year 2020 and then goes to 2021, it's just like, well, those are the darkest, deepest days of COVID. And you pretty much couldn't get any better with executing your processes and selecting patients than during the middle of COVID. So I'd almost like to see some of these data like longer term than just these last couple of years when the pandemic was in deep swing throughout Europe, to see if these survival metrics are about the same or whether they've improved their processes kind of level out after this, and whether it is just all patient selection or whether if patient selection stays stable, do the processes improve? And we always talk about patient oriented outcomes. This is great. I'd also like to see some surrogates as far as like their, the rest of their data as far as like each individual step in the process to correlate with this, that kind of thing. So, I mean, they have the low flow stuff, but cannulation minutes, that doesn't seem to have changed that much is the thing. So, anyways, it's interesting. It's certainly interesting to see a good glimpse at their program, and I'm glad that they're going to keep on working on it. And again, you always think about, is this the most effective deployment of resources for a hospital and a health system as well? Not to trivialize the saving of any individual life, but there's really only a handful of post-arrest patients compared to potentially the number of patients you could save with different public health interventions.
Yeah, no, I think that's always the big question. The data out of Seattle where, they put a ton of money and resources into this and really didn't get that much out of it compared to working on bystander CPR, defibrillator placement, so on and so forth.
Double defibrillation, dual sequential. All right. I'm just going to mention one little article to finish off called Comparing the Canadian Syncope Risk Score to the Final Emergency Department Diagnosis and the Model Without It, a secondary analysis. A lead author is Hadi Mirzfalian, and they're at the Tehran University of Medical Sciences. And I just kind of wanted to mention this little research letter because it refers to a clinical decision instrument that I feel like is potentially in wide use, the Canadian Syncope Risk Score. And if you recall, the Canadian Syncope Risk includes elements such as vasovagal syncope trigger, heart disease, abnormal ED systolic blood pressure, abnormal ECG troponin, and then the physician's final ED diagnosis as predictive of 30-day outcomes. However, as you can kind of obviously see, trying to use a risk score that incorporates your final diagnosis to come up with your final diagnosis is a bit fraught. So this group, which includes Ian Steele and Venkatesh Thrigunasambandamurthy, reanalyzed the data set from those 8,000 patients enrolled in the original study, included some more granular detail with respect to the serious outcomes. And it's just a brief research letter, so it doesn't really delve deeply into all the features. But removing the physician gestalt from the objective score clearly weakens its sensitivity for serious diagnoses, with an area under the curve dropping from 0.88 to 0.84. But both these pieces of objective risk stratification still outperform the ED diagnosis alone, which is 0.79, although the study was not really designed to measure the AROC of clinician gestalt. The short of the long story being, if you're going to keep using the Canadian syncope score, yes, injecting clinician gestalt into the equation gives you the best result, but effectively you're incorporating the information you can't otherwise be capturing with objective data. And whether you're sort of, self-fulfilling prophecy sort of way of getting to the end by jumping to the end. And these authors say basically using clinician gestalt in this fashion is inappropriate, and these tools should be rederived without it, because once a tool like this enters routine use, the scoring from it starts to influence gestalt in again, which will feed back and ultimately find us the final scoring in the end.
Yeah, I thought the most interesting part of this, and it's not isolated to this article, I think we're seeing it with almost all the syncope articles published over recent years, is the decreasing risk of syncope that presents to the emergency department. Back when these rules were made, it was like, 10% of your patients with syncope were going to have a really bad outcome. But if you look at this data set, 3.5% had an adverse event, and like it was less than 1% that died, less than 1% had what we would consider a bad outcome from a arrhythmogenic perspective, a heart attack perspective, a pulmonary embolism perspective. And so the actual risk of presenting to the ED with syncope is far less than it used to be.
Well, I don't know if it's far less than it used to be. Our perception of the risk is far less than it used to be. I'm pretty sure everybody who came to the emergency department back in 2000 had the same level of risk from their syncope. They still had the same level of risk of going home and having atrial fibrillation or what have you, potentially, unless you think our diagnostic acumen at that point was not as astute.
Well, I don't know. Like, if you go back and read like the old San Francisco syncope rule articles, so on and so forth, they cite like a adverse event rate of like over 10%, right? And so, I mean, the protoplasm might have changed, right? We control heart failure much better than we used to. You know, patients have a lot more of primary care in those areas that maybe the patients who are presenting just aren't as high risk as they used to be.
Or maybe we're just finding patients with CTPAs more frequently and finding all the PEs and finding our better troponin testing. And we're actually picking up different diagnoses, and we're not coding these patients as syncope anymore. Now they're NSTEMI, now they're PE. And so the patients who are left over as quote unquote just syncope that we end up sending home are actually much more medically clear than they used to be. I'm not, maybe.
Yeah, I mean, either way, having a negative workup in the emergency department and being discharged home or even be admitted to the hospital, you're at much lower risk of a bad outcome than you were when these original studies were done. And so one has to wonder, what are we trying to prevent at this point anyway? We're at a pretty low risk already. You know, you can't get lower than 1%. It's pretty hard. And so we might just be done.
Yeah, I kind of wonder if there's like trainees out there listening to this and they're going, people used to admit syncope. Like when I trained, we admitted like almost every syncope patient to the
Almost
hospital.
everybody. And they all sat around and nothing happened to them, except for a few had something really bad happen to them, right? And so
barely any, like, or they picked up the their paroxysmal atrial fibrillation on tele overnight, and it's like, okay, well now we'll start you on an anticoagulant. Great, here's your warfarin.
I do have to consider that the baseline risk is going down, right? And again, that might just be because we're categorizing patient differently. It might be a change in the milieu of patients that are presenting with syncope. We might have better tests, so we better identify the high-risk patients earlier. But either way, it does seem that the outcomes, it's far safer to discharge a patient with syncope than it was 20 years ago when these original studies were.
It never crosses my mind to admit a patient solely because they had syncope. It's like syncope plus they super high risk story. They look like crap. They're really frail. They don't have good support at home. There's like a whole bunch of stuff that goes into admitting somebody with syncope that just doesn't even cross my mind anymore.
So maybe we don't need a rule. Was my point.
Well, I mean, they say clinician gestalt wasn't quite as good as their remaining objective bits.
Clinician gestalt wasn't quite as good at finding a bunch of shit we don't need to find.
Well, 1.6 incidental findings per patient to follow up after their evaluation for syncope.
Yeah, exactly.
Okay, that wraps up May.
Yeah, that does it. May in the books. As always, any questions, comments, or concerns, we can be reached at annalsaudio@acep.org. Otherwise, until next month, this was Rory Spiegel and Ryan Radecki, and this was the Annals of Emergency Medicine podcast.